A very good afternoon to all of you. My name is Dr. Srishti Jain. I am the Additional Director and the Associate Professor in the Department of Critical Care, and I'm also heading the Department of ECMO Center in the Institute. So let's go ahead with our topic for today. My topic for today is something not which we study every day. It is all about the checklist. Why are we talking about the checklists in ECMO? So let's see and understand. So today we will understand ECMO from counseling to initiation and the checklist manifesto. So why we are talking about checklist? This is a very nice book, The Checklist Manifesto, which I happened to read some years ago. It has been written by Dr. Atul Gawande. He's a cardiovascular thoracic surgeon and he's working in US. And he wrote this book to understand that there are certain human factors which get activated when we are working in a stress zone. So we tend to forget certain things, and certain things which we forget can really harm the patient's life. So wonderful book which I would request all of you to go through is this Checklist Manifesto. And it says that checklist provides reminder of only the most critical and the important steps, the ones that even the highly skilled professional using them could miss. So yes, today we will study all the checklists that we use in our department to prevent errors. So when to shout for ECMO for a sick acute heart failure or the ARDS patient. So this is our understanding of when do we initiate the ECMO. As you can see here, for the cardiac ECMO, you initiate the cardiac ECMO when the patient is having a very low ejection fraction and the cause for the heart failure is reversible, right? So this is very important that for whatever disease we are initiating ECMO, we should understand that the disease has to be a reversible disease. Similarly, for the lung ECMO or the pulmo ECMO, we initiate ECMO when the ventilator is failing to provide the oxygenation and the underlying disease is the one which is reversible. We all used ECMO to save the precious lives of our COVID patients when the ventilator used to fail, despite the ARDS net protocol application of the ventilatory settings. So making sure that the medical interventions have been deployed and their futility of harm understood if ECMO is delayed. So we need to understand that the indications are not always black and white, and we need to have a multidisciplinary team meetings at times to come to the conclusion whether this patient needs ECMO or not. This is our ECMO referral form, and whenever we get referrals for ECMO from the outside hospitals, we send them this form. We also have a checklist in the Google Forms format which they can autofill on their mobiles, and this is how the checklist would look like. They have to enter the patient's demographic data, then which hospital has requested, what are the past medical illnesses of the patient, what are the comorbidities of the patient, what is the reason for the respiratory failure, current respiratory status, that how many days the patient has been intubated, what are the settings of the ventilator, what are the recent blood gases, and the attempted treatment which has already been deployed. So this also acts like a checklist which helps the referral team to understand that why are they referring the patient for ECMO and how early the ECMO initiation has to be planned. Now, step number 2, we need a timely multidisciplinary team discussion. So usually whenever we are in doubt whether the ECMO is needed or not, there is a team of 2 ICU consultants, and we also involve the cardiologist if there is the need for the cardiac ECMO, that is the acute heart failure, and we involve the pulmonologist team whenever we have a patient of need of the pulmo ECMO, right? So we have a multidisciplinary team meeting with the different specialities, and we want to make sure that whatever the treatment methods that can be offered to the patient before ECMO have been offered. For example, in a pulmo ECMO patient, we make sure that the bronchoscopy, if needed and if can help, has been done. For a cardiac patient, we make sure that the angiography has been done if needed, or whether we are going to bridge the patient for the primary PCI after taking on the WECMO. So the plan of action has to be clear. So the Avenger moment is when the ECMO alert has been created and all are on the same point or all are on the same thought process that this patient needs ECMO. So yes, this is Lord Krishna and that is the final Brahmastra that ab patient ko ECMO ki zarurat hai, and that's the Avenger moment, right? So that is another checklist done once we have decided that yes, this patient needs ECMO. Now what next needs to be done? Most important step is the counseling of the family members. So we initiate the counseling in our audio-visual counseling room, and here is where our doctor sits. These are the family members, everything is being recorded, and we counsel the patients based on the SPIKES protocol. So SPIKES is a mnemonic and it really helps us to not to miss any step of counseling whenever we are counseling a troubled family and we are about to declare a bad news. So S stands for setting up. As you can see, the doctor has no distractions. He's kept away his mobile phone. He's sitting in privacy with the family. Perception, very, very important part. We need to first listen to the family member. The most important part of communication skills is being a good listener, and that is where most of the times we miss this. So we have to be a patient listener. We need to understand what are the perceptions of the family members, what they understand about the disease, whether they are mentally prepared or not to go for such an advanced treatment methodology called ECMO. So we need to understand what is their perception. Then we do the invitation, that is we ask the family's patient, we ask the family whether they want to know anything else and whether they have understood anything or not. Then we impart them the knowledge, we slowly break the news that this patient is very sick and we need to initiate an ECMO for this patient. We need to be respectful about the emotions. There can be an emotional outburst. We keep the tissue paper box near them, and it's a very kind gesture, just hand over the tissue paper, offer them water, just keep a consoling hand on their shoulders. At the end of the day, I strongly believe that spirituality and being an emotional, kind human being is the core thing that a doctor should have, right? At the end of the day, they come to us whenever they are in pain. And it is our due responsibility that we look after their emotions when they are in pain. And the last step of the SPIKES protocol is to summarize. And to give them an option that they can meet us again, right? So these were the steps of the SPIKES protocol. And we make sure that we don't miss any step of this checklist. Then when we are counseling the family, once we come on the step where they understand that yes, the ECMO support is needed, we counsel them in both Hindi and English. We have the counseling forms prepared and we can provide these counseling forms to you on your email addresses, and we counsel in Hindi and in English, right? So what is ECMO? ECMO का उपयोग कब करें, कैसे करें, क्यों करें, ECMO के फ़ायदे क्या हैं, नुकसान क्या हैं, किन मरीज़ों में लगाया जाता है, साइड इफ़ेक्ट्स क्या हो सकते हैं. We discuss all these things in the language which they understand. So this is how the counseling takes place. We tell them all the risk factors, all the problems that can arise because of the ECMO facility, right? So this is finally the consent form. And we take consent from the family members. We invite 2 family members to consent for ECMO, and we make them understand each and everything before they sign, and we give them a copy of this document so that they can re-refer. As we all know, when we are in the counseling room, there are lots of emotions involved. They might be under a lot of stress and they might need to revisit this document to understand it again. So we give them an option for this. Step number 4, very, very important, is the financial counseling. As we know, it is a labor-intensive therapy and it is also a costly therapy. We need to understand whether the RGHS services are involved, whether the Chiranjeevi services are involved, and there is a very, very important role of the financial counselor in the healthcare system. We have a financial counselor who would sit down with the family, make them understand the costs incurred, and would also take the signature of the family members so that they are also aware that they have been counseled about all the costs that could be possible while the patient is on ECMO therapy, right? Then the step number 5 is the second ECMO alert, and that is when the consent has been done. And that is the Invictus moment for all of us. I'm sure many of you would have seen this movie Invictus, a wonderful movie on the life of Nelson Mandela. That how during the apartheid era, when he became the first black president of South Africa, how he united the country. So that is the kind of moment which we feel, because when the ECMO has to be initiated, a lot of team members have to come in play. So this is the ECMO team we have. We have an ECMO physician, a cardiovascular thoracic surgeon, a perfusionist, cardiac anesthetists, and the interventional cardiologist, intensivist, ECMO coordinators, ECMO referral coordinators, ECMO nurses, physiotherapists, dietitian, and that is how there is a big team of ECMO and all have to come into play, right? So when the consent has been done, that's the yes sir moment, and whatever is the time of the day, whether it is 1 a.m., 2 a.m., everyone has to leave their homes and then rush to the hospital. Yes, as we can see here, Mr. Beam running, getting ready to come to the hospital. Okay, and that's our ECMO team here. That is our ECMO center. And this is the theatre. We usually do the cannulations of the WECMO in the theatre, and for WECMO as well, if there are complicated patients, there we anticipate some kind of cannulation difficulties, we mostly do the cannulations in the theatre, right? So again, another checklist moment. I feel really happy that Google is there. Google is the new god. Thanks to Larry Page and Sundar Pichai for making Google so easy for us. So we have the facility of the Google Drive, and all the ECMO policy documents are uploaded on the Google Drive, and whenever the nurses want to refer or want to take any of the checklists, they can just go to the drive and they can take a printout of all the checklists involved in the management of the ECMO patients. So there we go. So this is our institutional ECMO protocol. As you can see, everything is written down. ECMO cart, insertion, cannulation site dressing protocol, drug protocol, aspiration protocol, performing a post-oxygenator gas protocol, attachment of the hemofilter to the circuit protocol, and all the troubleshooting possibilities have been mentioned in our ECMO protocol book. Right? So we practice evidence-based medicine, which is based upon the clinical experience on the evidence available on the literature. So basic level of protocols, they bring everyone on the same page. Then step number 6 is the assessment of the vasculature. As we all know, in ECMO, we cannulate the larger vessels of the body. So we need to know what is the diameter of these vessels, what size of the cannula will be needed to cannulate the blood vessel, right? So this is the sonocyte machine which we use, and this is how we measure the diameter of the artery or the vein, whatever has to be cannulated, and we also make sure that there is no clot or thrombus inside the blood vessel, right? So we calculate the size of the cannula depending upon this formula. We want to use the largest size possible of the cannula, but at the same time we also need to ensure that there is blood flow present around the cannula. So neither too big, neither too small. Okay, that's how we choose the size of the cannula. So step number 7, as we discussed, is the selection of the appropriate size of the cannula. We use these charts depending upon the patient's body weight, height, body surface area. We calculate the appropriate size of the drainage cannula and the return cannula. So these are the cannulas which we have. We use the Mackett cannulas or we use the Edwards cannula depending upon which side of the body has to be cannulated. Step number 8 is ECMO cannulation and priming of the circuit, which finally leads to the ECMO initiation. These are the videos from our own department, and as we can see here, this is the drainage cannula, the blue cannula, that is the drainage cannula, and we are draining from the left femoral vein here. This is the video which is showing us that how do we initiate the ECMO once the cannulation has been done, right? This is the circuit. They are bringing the circuit in together and they are planning soon to connect the circuit to the cannula. So as we can see here, we are inserting all the cannula. and these are the real life videos from our department itself. So this is the another video. As you can see, now they are finally ready to attach and initiate the ECMO cannula circuit. So this is the cannula. They've cut the wire, that is the tubings, and then they would be attaching it finally to the circuit, right? And as you can see here, they are almost ready to attach it to the circuit. Okay. We do all our cannulations guided under the transesophageal echocardiography, because we need to be very sure what is the distance between the tips of the two cannula. So drainage cannula and the return cannula, we need to be very sure that they are neither too close, neither too far. So the approximate distance we want is around 10 centimeters, right? So RA SVC junction and RA IVC junction, that is where we want to see the position of the cannulas. So under the TOE guidance, we see what are the cannula positions. These are the real-time videos again from our department, right? Next very important step is transfer of the ECMO patient from the theatre to the ECMO ICU. So again, we have a checklist for this as well. Why? Because we know it is a very stressful zone. Lots of people are involved and we don't want a single mistake while transporting the patients. So we check everything, whether the alarm settings have been reviewed, whether the oxygen tank is full or not, whether the tubings and the clamps are available, all the blood tests have been checked, hand crank is available, cannula position is same. So we make sure that we have this checklist, everyone in the team is on board, and then we safely transfer the patient to the intensive care unit. So this is how we are transferring the patient. See, you need to be aware how the lift will go, whether the bed will enter into the lift or not. So all these logistics have to be made sure that they are in right place. So we have another checklist for the ECMO transport trolley. So whenever we are transporting the patient from, let's say, theatre to the ICU or for CT scans, we have a transport trolley, and these are the components of the transport trolley. So all these sizes of the cannulas, the guide wires, the sutures, the items, cannulation set, everything needs to be checked, and we make sure that we have all the items on the table available. The next checklist is the ECMO safety data review checklist. So this is the checklist which we make sure that we use it for the day-to-day assessment of our ECMO patients once they are in ICU. So if it is a heart ECMO, we do the echoes every 6 hours. We check for the contractility of the heart. For example, we see a lot of patients coming with sulfur overdose, and these patients usually they start recovering in 36 to 48 hours, and that is the half-life of the phosgene gas. So we do regular echoes to see whether they are improving or not. We see the condition of the lungs, of the monitor, of the ECMO flows, ECMO RPM, and on the ventilator, what is the oxygen requirement. So we see all these things to make sure that how the patient is progressing, right? Then another part of the checklist is the recent labs. So we need to know the hemoglobin, the platelets, the lactates, the bilirubin, pre and post oxygenator pressures. So continuous monitoring of the pressures is ongoing here. As you can see on this monitor, a separate dedicated monitor to monitor the pre and the post oxygenator gases on the ECMO. Then if there are any flow issues, as you can see, we have made the video of the cannula. As you can see, this is the bright red cannula because it is the oxygenated blood, and this is the drainage cannula part, which is the deoxygenated blood. So we see the flow issues, we see the regular blood gases here, we check for the heparin, what is the need for the heparin, we monitor the APTTs regularly, we do the ACTs hourly initially, and then we decrease the frequency once we are sure that the rate of the heparin has been settled. Bedside ECMO safety inspection checklist. So we see the tube clamps are available, we see for the cannulas, we see for the any clots with a flashlight on the oxygenator. So in every shift we monitor with the light whether there are any clots on the oxygenator or not, right? and then we look for the pump, if there is any chattering or not, whether the flow sensors are all right or not. We use a cream to put in the flow sensor, and we need to understand when do we need to again put that cream in place, ensure that the heater is on and connected, and the correct settings of the sweep gas flow. So all these are the parts of the daily monitoring and the checklist. This is our ECMO unit, and this is our very own patient where we are seeing the flows, RPMs, the leg monitoring, and all the details are being monitored, right? Then comes the perfusionist data sheet. So this is the record keeping of the perfusionist. So we need multiple people to record at various steps so that nothing is missed and we are able to identify any abnormality timely. So this is the checklist of the perfusionist where they write about the ventilator settings, the ECMO pump settings, pressure settings, blood gases, ACT and the heparin doses. And they also monitor regularly the legs, because in the VA ECMO, in the arterial cannula limb, there is a possibility of limb ischemia. So we need to be very mindful about that, right? So this is how the perfusionist data sheet would be filled and the data recording would take place. Heparin. Heparin is a very, very important part of the ECMO management, because there is such a lot of extracorporeal blood flowing out of the body and it can get clotted. So heparin is a very important drug, and this is the heparin infusion protocol that we maintain in our department. Then comes the VB ECMO weaving protocol. So whenever the patients are on VB ECMO, when they have the lungs which are pathological, this is the checklist we use to understand whether they are ready to wean or not. So we do the 100% oxygenation test. We then check the blood gases. We see whether the patient is comfortable or not. We slowly come down on the ventilatory settings, and then we come down on the ECMO FiO2 and the ECMO sweep, and this is how we decide whether the patient is ready to be decannulated or not. So the lungs are improving, the patient is able to sustain the oxygen saturations with the minimal ECMO support, minimal ECMO FiO2 and sweep, and that's how we understand whether they are ready to get decannulated or not. And for the VA ECMO, we want that the heart has started to pump nicely, ejection fraction has improved, urine output has improved, the lactates have fallen on the ABGs, and that's how we understand that whether the patient is ready to be decannulated from the ECMO or not. So we start decreasing the ECMO flows gradually. We come down till 1.5 liters, and once we are sure that the NORAD and the vasopressin requirements are not increasing, we go ahead with the decannulation protocol, right? So ECMO decannulation, again, we have a checklist for this as well. And this is the ECMO cannulation removal checklist, that who is the operator, ultrasound is available or not, whether the surgeon is present or not, because sometimes, especially in cases of VA ECMO, we need the repair of the femoral artery. You know, most of the times we have to go for the femoral artery repair because that is good for the patient, prevents the formation of pseudoaneurysms and the clot formation later on. This is how we take the suture and we decannulate the venous cannula. So this is the venous cannula which has been decannulated from the patient, right? Then comes the post ECMO decannulation critical care best practices. So no one can deny that the overall outcome of the patient depends upon the good critical care practices. We all have been reading about the fast hugs BID. We have this another mnemonic ABCDEF mnemonic from the ICU liberation. So that is the ICU liberation bundle. So A stands for assess, prevent and manage the pain. B stands for both spontaneous awakening trial and the spontaneous breathing trial. C stands for choice of analgesia and sedation. We want the least possible sedation and analgesia for our patients so that they don't go into delirium. And D stands for delirium, assessment and prevention of the delirium. E stands for early mobility and exercises. We can never negate the importance of good nutrition and physiotherapy in our patients' recovery. And F stands for family engagement and empowerment. Trust me guys, when the patient is in ICU, he is not able to talk to you and the family members are outside standing apprehensive. It is our duty that we sit down daily with the family and communicate with them. Studies have shown that whenever you sit down and talk to people, and even if you give less time, it is far more effective and satisfactory for the families Don't talk to them in front of the lobby or in front of the ICU or at bedside, because it's a high emotional zone. Many people are there listening to your conversation, and the family also feels that they have not been given good, adequate time in privacy. So yes, take time for daily counselings. It is a very, very important part of your management of your ICU patients. So we look after the COT bundle, the CLAPSI bundle, the VAP bundle, the SSI bundles. All these bundles are an important part of the family. And when you follow all these checklists and when you don't miss any step, this is what you get. That is the success. So this is our patient who had presented with the acute cardiogenic shock, and this is how he recovered, and he was ready for discharge, and he is standing with all the members of our ECMO team together. So teamwork. Never forget the importance of teamwork. Teamwork is the ability to work together towards a common vision. A beautiful quote by Andrew Carnegie. Many of you would have read the book Think and Grow Rich by Napoleon Hill. And in that whole book, Napoleon Hill talks a lot about how Andrew Carnegie became a great steel mastermind in America during those times and became such a rich person. And that was the quality which he had. Thank you so much.